So today I'm speaking to Partha Carr. Partha Carr, in addition to being a consultant endocrinologist in Portsmouth, is also National Specialty Advisor for Diabetes and Obesity and the Associate National Clinical Director for Diabetes. Partha, welcome to the podcast.
Thank you. Thank you for asking.
So I'm really interested to know about when you're at my stage. I'm a junior doctor. 26 years old. Did you have kind of the aims to hold the kind of roles that you're holding at the moment?
I think it would be unfair to say yes to that, if I'm honest. I think you start off in your journey, and I think a lot of the time it's about trying to get a sense of what's happening all around you. Times are different, and I've never catered to the view that, oh, in my time things were amazingly, difficult and all present. I mean, that's just nonsense because, some of the perks that we used to get, none of the present people get, right? So there's swings and roundabouts to everything. So we had yes, the hours were tough, but I think the flip side of it was also you had a lot of time to with your friends and stuff and enjoyments and really solid friendships because you were part of a team. So, and I don't think at that point I would say things like, I'll be doing this sort of national role or anything crossed my mind. I think it was more about, a lot of it was about enjoying the job as much as you could do. There was a lot of, we work hard, we play hard, that sort of thing. And it was quite good. It was good fun. I really enjoyed those years, I would say. It was great fun as far as I was concerned.
So I was reading that you trained in Calcutta,
Mm.
and I was wondering what the transition was like. As a kind of international
Mm.
medical graduate coming to the UK.
So when I finished my training in Calcutta, India, I came over here, and I think one of the good things that I did at that time was taking on a clinical attachment job. So you didn't have to. You basically, shadowed people, were allowed to do very few stuff, but you were. And I had some amazing SHOs and a house officer in those days, and they were brilliant. I mean, amazing the way they looked after me. We were good fun. They were good friends. We still have that friendship. And I think that was a big, big plus. And a lot of people go straight into the system, which is a big shock. So I'll give you one example. The first time I saw a arterial blood gas being done, I was like, whoa, what? What's going on? They took some blood out and put it into a machine and something came out. Whoa. I mean, you would never have that in Calcutta, right? But I think there was that 6 or 8 months that I did was absolute gold because I think it introduced you to a lot of stuff. And as I said, having that support and not being lonely was very, very good. I was introduced to PlayStation and FIFA in those days. That was, yeah, I never seen anything like that. It was great sort of time pass outside your work. So I think that helped a lot when I eventually and I started at the
Mm.
lowest rank. So I started as a house officer. I didn't want to jump through the system because I'd done something in India. And I think that was also very good. You started as a house job and you learned from absolutely the start and did everything that was asked, and then an SHO and moved up. So, I think I wouldn't say it was incredibly tough, but mostly because of the support I had around me. So I was very lucky in that respect.
And were there any sort of stories that kind of stick in your mind now, like from those days as a junior doctor, that kind of, uh, you know, I'm conscious that some of the work that you've done now, you've really contributed to changing
Hmm.
the models of care. You've improved upon some of the things that were being done in those days. I mean, were you conscious that things weren't as good as they could be?
Yeah, I mean, I think one of the ethos you learn, so I'll give you a good and a bad. The good was, I think, the really good was you learn the value of being good senior mentors, right? And I talk about consultants and registrars and the value of that. And I was blessed to have some really good consultants, right? And I think that became an ethos that, how do you, nurture the generation next? Simple things like taking people for a cup of coffee, and it's talked about in glowing terms. In those days, it was quite natural. You did your night shift, your consultant would come in with breakfast in the morning. It was quite normal, and he would go like, "No, absolutely, we must." You really felt part of the team. You felt valued, and it wasn't a big thing, right? He would just bring in some sandwiches he had done in his kitchen, but he had made the effort, right, to bring them in for you, and it was great. You had some ketchup, and you sat down in a mess and had it before you did the ward rounds. So I think that taught me a lot about that, and I try and sort of keep that ethos going. I think it also taught me that Consultants are incredibly powerful people. They are very
Mm.
powerful people. And I don't think people use that power for the good enough for their own trainees. So things like you'll hear nowadays, and I'll give you one example of that, whereby and nowadays you hear about, I had a wedding booked, and HR said, no, you can't, and they made me change my shifts. I can absolutely tell you that would not happen when I was a junior. Your consultant just step in and go like, I'm sorry, but no, he's going. Find somebody else to do it. And that was brilliant because you just felt you knew you would give 125% for that guy or that person back again because they had stood by you when you wanted a time off and all that.
Yeah, definitely.
So I think that was a great learning point. I think the negative was also the other flip side of it. If consultants wanted to be really nasty to you, and I think I learned a lot about the value of role modeling. So if you had somebody who was from, you would say, from your own community, so to speak, from an ethnic minority background, I think their standing up for you was very important, and how they stood up and didn't stand up for you was also quite relevant, and what they said and what they did. You still see a lot of that. So I think for me, those were some big things you learned in my junior doctor's day. Life could be enjoyed, but I think it was more about what I've always say nowadays to trainees is that there is no experience in any firm which you don't learn from. You either learn about that is what I'm going to become, or that is what I'm not going to become. But you learn, right? Either ways,
Yeah.
And I think there is nothing called you personally will have a bad experience. There's nothing that would not stand you in good stead. If you really, really dislike somebody doing something, well, don't do that yourself when you grow up, and don't do that to your junior. That's as straightforward as that.
It's it's not often that I hear consultants who are consultants nowadays saying, yes, consultants are really powerful people. It's interesting to hear you say that because I don't know if you agree with this, but my sense is that a lot of consultants these days feel that they don't have as much power as consultants used to in the generation before. And this is for lots of reasons,
Mm.
like, oh, the managers have the power now. And, we have to sort of, consider things about budgets, and they have to be done according to these regulations and bureaucracy. And it's not like it was where, as the consultant, you were running it, everything. I mean, do you see any kind of do you think that argument holds water at all, or
No, I don't. I don't. I mean, I'm in the same NHS as everybody else, right? I do a full time job, and people can come around and talk to our juniors if they want time off, and that needs to be done. It needs to be done, right? I don't care. Consultants are still incredibly powerful, right? We've done a lot of things in our department, and there is a reason. Let me give you an example. There is a reason our last 3 consultant appointments have all been our trainees because they know what they're coming into. We will
mm,
stand up for them every single time, and that is an important ethos of where consultants are very powerful beings. They still are, right? They still hold a lot. So I think what I do encourage consultant colleagues to do, and as I said, people can't say I'm junior. Well, I've been a consultant now for nearly 14 years, and I do a national role, etc. And I say the same thing to our trainees in a national sphere. Tell us what you need, right? For example, right now, one of our trainees has to go back to Pakistan because his dad's ill. So HR came to me and said, "What should we do?" And I said, "Well, there's no debate. We decide that when he comes back. For the moment, he's on leave. What we convert that to, what annual leave needs to be, what needs to be unpaid leave, it's an irrelevant debate at this point of time. His dad gets better, comes back to this country, then we'll discuss what we can do. But at the same time, we can't just say this is going to be all annual leave, because annual leave is something for you to take time off from your work and enjoy, not to go and do things which are stressful. So, and HR have said fine, fair enough. So I don't cater to the view that consultants can't. I don't think we try enough. I think there's a degree of, I see learned helplessness about people feeling, and there's a lot of chatter about, oh, they don't let us do that. I have never faced that in my career. When people say you can't do it, I always ask why not. Because my view to all the trainees who will become seniors at one stage is that at the end of the day, my experience, I've had my share of ruckus with lots of people in the system. One thing I've learned:
mm,
if you're doing things which fundamentally everybody else believes to be right, then you'll get your way through. There isn't a single, the problem is when people, it's one of those things, isn't it? It's a bit like racism or sexism or homophobia or anything, right? If you're going to keep quiet, you're not going to change it, right? And if you're going to, well, nobody listens to me, well, a lot of people talking together does raise a voice, okay? And the same is with looking after your generation next. We all go like, well, what's the point? It's never going to change. And I think that's quite an important message.
It's music to my ears actually to hear you saying, some of these things. I think that's maybe why you're like quite a refreshing voice in the kind of in the mainstream discourse. I know that so I have uh, friends who are about my stage that they would absolutely love if the department gives them the time off that they're wanting, but it does feel like kind of a battle, and they end up thinking, well, what's the point of speaking up, or it's going to be too much effort to speak up. You talked a little bit about, you've had your fair share of kind of ruckus, but this is a really interesting question for me. Like, how do you learn to deal with those better and have those kinds of disagreements in a more productive way? Because I think if people knew that, they might feel a bit more comfortable speaking up themselves.
I think one of the problems that we have, and I see that a lot even in these present pandemic times, right? People think leadership roles, right? Leadership roles are about personality, charisma, all that sort of stuff. It's not. It's about the skills to negotiate, right? And for that, you need to bring off a mixture of what I call fire and ice. You need your charm, but you need your firmness as well. And that doesn't happen overnight. It doesn't happen if you go to courses, I'm afraid. That happens a lot with experience and learning it the wrong way as you go along. I think what I say to people is don't be afraid. If you feel you're in the right, speak up. You'll be knocked back 2 times, 3 times, but don't get sort of go like, what's the point anymore? You need to stand up and do that again because in your heart, you should believe that you're doing the right thing, right? And I think one of the biggest tips I always give is to find allies who will support you in that, somebody senior than you. And that is important. Amongst 10 consultants, if 8 of them say, well, what's the point? You'll always find one who will stand by you. And I think you need to try and find them as a mentor and run things by them and see whether they will stand and support you. Okay. And that
Mhm.
is quite an important message, which I give is that because the system has got a very good way of shutting people down, riding it over and go like, well, you go and stand in a corner for doing that. And when that happens, that's where the role of the consultant becomes to turn around and say, no, I disagree. So I think what I say to people in the absence of that, you should not give up your passion to fight and stand up, but you might try a slightly different technique next time around. So I think that's the important message that I give. You don't always have to go blunderbuss or angry and steam coming out of ears. There is a place also for that, right? It's not everything is just about, but I think a lot of it is about charm. A lot of it is about, but not in the sense of just, you will meet a lot of charming individuals who don't do anything, right? And that's no good. What you need is a skill to negotiate. Is that, and I think that's important where you have that mixture. So you've got to keep trying a fair few times rather than sort of give up. So if you're talking about
Mhm.
holidays, you go up, go one step up, in the system, try again, try another person. It's not a pleasant place to be in. I used to be the mess president at one point of time. I was involved in the banding negotiations in those days. So, you know, and I can absolutely tell you, I've done a fair few things and I've got truckloads of failures as you've gone along, right? Truckloads, right?
Mhm.
But that happens. And I'll probably give you one example. This is when I was a consultant and I was battling for inpatient nurses for safety. And I remember going to this meeting, and because I had sort of brought it up to the meeting, I said I want to talk about it. This particular manager in the middle of this room, where there's about like another 10 people in the room, told me to leave, get out. That's what he said to me. Get out for bringing this up, and I just want you to leave. We're not having this conversation. I remember walking out of the room, my ears completely burning, right? This is my second or third in my consultant job.
I can imagine.
Yeah.
Yeah.
And I remember turning around to him and saying, do you know what? This will happen because this is about safety about for patients and this will happen and you on the other hand will not be around to see that. And guess what, you look back 6 7 years later, he's moved on because the job and etc. Do we have those inpatient nurses? Yeah, absolutely we do. I just kept on going. I went above him, then above him, went to a CCG, complained here, complained there, went and said, this is about safety, and finally the system relents. So I think it's not easy plain sailing by any means whatsoever.
It's kind of about having that persistence, isn't
Yeah,
it? That's the kind of
got to be
theme that
persistent.
I'm getting here. I want to maybe spend a little bit of time on this because I want to talk about Super Six,
Mm.
and for people who are listening that don't know about this, the the model of care sort of when you were a new consultant. there was a kind of rapid transformation,
Mm,
and I was kind of surprised reading about this, just how radical it was, because the idea itself doesn't sound that radical. It's just kind of, well, we're going to do what we can do in the hospital, and we're going to teach the GPs how to do the stuff that can be done in the community.
mm,
And there were 6 things that you were going to do in the hospital.
mm,
But then it was this statistic which was that 90% of the patients on the lists in the clinic were going to get discharged to the community.
mm.
And I'm kind of thinking, how did you manage to get that through? Um,
So I think, I always talk about changes in the NHS bringing up opportunities, right? And we flipped it on its head because we never said it was our model. That was the key thing. So when he started off with the Super Six, we went out and we did lots of meetings with GPs and nurses. And I was in a meeting and one GP stood up and said, well, I'm not quite sure what happens in the hospital. Why do so many patients go there? And the whole ethos of that conversation, and that's an example where we were not in the, I would say, the more alpha male setting where we're going to write this is, and I think a lot of models fall down because consultants come out and say, right, this is the model and that's what needs to happen. And lots of GPs go like, well, thanks very much, but not really. And quite rightly. Well, what we did was slightly different. We said, well, what do you want to be in the hospital? And I remember one particular GP in those days, he's retired, and we became really good friends because he became one of the person I worked with. He said, well, I think you should just basically shut down the diabetes department, make sure all of you come and work here. And I said, okay, well, that's fair enough. How are you going to see the pregnant patients? And he went like, oh, that's a good point. Okay, pregnant patient needs to go to the hospital. And then we had the meeting. I said, why don't you guys tell me which ones should be in the hospital and really should not be with you because of multiple grounds of safety, multidisciplinary meetings, whatever. And so the 6 that came out were the 6 chosen by our GP colleagues. There was foot care because it needed an orthopedic surgeon. There was type 1 care, well, if it's complicated because it needed insulin pumps and all this sort of stuff. The GP said, I'm not doing that, but it's okay. Pregnancy, and the rest of it, renal, dialysis. So it all joined clinics. And so that worked really well, that approach. And then he says, what are we going to do with the rest of the patients now? And so some GPs were like, well, I'm not just taking them on, man. I said, well, why don't we do one thing? Why don't you not take them on? Why don't we, when we go to your GP surgeries, just go through the list and see how they're doing? But there's truckloads of patients who are actually doing quite well and just turn up for saying hello. And you see them anyway as part of your QOF to do their reviews. What we'll do is we'll help you get your QOF better. And what we'll do is we'll make sure that the controls are right. And that approach worked really well because we went and sat in GP surgeries and went through the lists and stuff like that. Took a lot of time to convince everybody. It took about 4 years to get everybody on board, right? And get it all going. But now we're here, 11 years in, and it's works, and that's pretty much set. And lots of places are now adapting that because it's basically just going like, that's the way diabetes should be done. Why else would you go to the hospital? So that was interesting and intriguing. But I needed some, again, I go back to the point, I made about allies, and I had some great allies, Jim Hogan, Tim Goulder, GP colleagues, they were brilliant, in helping us make that thing happen. So, huge kudos to them.
And were you aware of having to overcome resistance to the idea during those 4 years? I'm
Huge.
wondering, kind of like, how did you do that? How did you overcome resistance from managers, or how did you overcome, resistance from people who weren't so keen on the idea?
So I think the managers, at the end of the day, I think managers work and they look at the bottom lines, quite understand where they need to make the budgets are, and that's their job, right? To make sure the process is okay, budgets, etc. And that we doctors don't always think about it, which I think managers find really frustrating sometimes that we don't. And you go like, well, hallelujah, let's just make it happen. So I think for us to bring the managers on board was very much about the financial modeling, where we said we would release this activity into the CCGs at that time liked it because that would be activity loss. But what we said to the department or the hospital managers was that we would release our sessions, consultant time, and that would be put into the community. So that came off the bill, the payment bill of the trust, which they liked. Mm-hmm. And our medical director at that time was really supportive as well, because he kept on saying, is this the right approach? And we say, yep, this will really benefit patients because it will help us focus on things that we need to focus on, foot care and pregnancy and stuff. The clinical, I would say resistance to it came from different quarters. And I think going into GP surgeries was really powerful because you would sit down with the GP and chat, right? And if they weren't on board, you would chat about different other things. And it wasn't immediate. It took, as I said, some time. Each of the visits would have different sort of parameters. Sometimes we would just talk about life. something to talk about, And then he became more sort of personable and friendly and stuff. And then he said, let's do some diabetes and stuff after we've all done our mutual slagging off of a topic we found common ground on. And then you would just build those relationships and go ahead. And it took time, but I think the practice nurses were also very powerful in their thing that actually is quite good to have a consultant here. We could run it by them and look, hey, listen, it might help your life as well. So all of those made a big difference, but it takes time. It took time, persistence, and a combination, as I said, of charm and sometimes firmness, sometimes saying this is about good care and all that, and sometimes about, come on, guys, together we can do this and all that. So it was a mixture of all sorts of stuff.
Okay. And sort of in, the legacy of Super Six is that, there's been reduced hospital admissions, lots of money saved because of that. But my understanding is that Super Six is still not, universal, national. And I think, what's your kind of understanding about why that's been a problem, sort of rolling it out, and what's the next steps?
Well, I think, people are getting towards it is what I would say. I mean, what I've learned along the way. So the Super Six was a name, right? It came out because we just came out with the name. One evening we're sitting down together, let's call it the Super Six. That sounds great. We always joke about it nowadays because since then Pizza Hut have nicked it, has a Sky Sports with the Super Six tips and all that sort of stuff. And I think what we have learned is that what we have also said is that it's not the name of the model, it's the principle. And I think lots of places, in fairness, have adapted it, but that's a classical NHS thing. They don't want to be using the same name because they want to be seen as that they had come up with it. So you've got different models in Leicester, you've got different models in Ipswich, different models in London. And I think for us, we have never had a copyright over the name. So we have gone like, whatever, I don't matter what you call it. I think Leicester call it the Special 7 or something like that. I was like, well, yeah, okay, whatever. You call it whatever you want, But I think for me, it was more about the principle of what happens in a hospital. And I think most areas have moved towards it. Now, uniform pickup, 100% pickup. I think we're up to, as far as I know, 80%. So it's a huge pickup rate across the country of the principle that this needs to be in community and better support in community. I think always there is a thing about some areas will have different dynamics in politics, relationships. And I think, as I said, people are not always very good at building relationships. So you'll have really fractured relationships between primary care and specialist care. And that becomes very difficult then to take things forward. But I think with these new systems that is coming up, the ICS and everything, I think you'll see more of that happening because there's no other way around it, right? If you want to do better care in hospital, just focus on the things that you need to do better. So that's the way I think these things are going. So yeah, it's a matter of time, I reckon.
So kind of after you'd kind of been involved in the work around, the Super Six model and the sort of the trying to improve the rates of hospital admissions in Portsmouth, when did you start thinking, oh, actually, like I might fancy doing some sort of bigger role to do with policy and diabetes? And
well, I hadn't actually, to be perfectly honest. I mean, it was more of so in those days, Bruce Keogh was the medical director of the NHS, and I was doing I think locally we were doing a presentation, and he was there in the audience, and he came up to me and said, "Oh, this is really innovative. I really like your way of thinking, and you're very much a maverick spirit. So let's keep in touch." And then I think 2016 March, there was a Diabetes UK meeting, and one of my big mentors and heroes is Stephanie Amiel. She's a consultant in type 1 diabetes in London, and she had done a nice guidelines on type 1 diabetes, and I was asked to do a critique of the type 1 guidelines in a public forum, which is hugely packed type 1 diabetes forum. And basically I stood up and said, what is the point in having these guidelines if it can't be implemented, right? It's a bit like just saying we should all have a Lamborghini, which is a lovely desire to have, but most of us can only afford much less than that. And so Stephanie stood up, we had lots of counter arguments, and she said, our job is to make sure, and then at the end of that, she said to me, if you're so passionate about type 1 diabetes care, why don't you go and do it yourself? And I had a brief think about it, and that sort of coincided a few months later with Bruce Keogh calling me in to NHS England, talking about future. I had given up my role as clinical director by that time in Portsmouth, so it was a bit of a sort of in a bit of a phase of relaxing and not doing really anything. And he said, "What do you think about joining the national team? Because we got Jonathan Balabji who was there, and me and Jonathan are absolutely chalk and cheese. So it's very much the, for want of a better analogy, I always use the example of Spock and Kirk, or Superman and Batman. He's your perfect gent, really good, thorough, detailed, your calm person, who can do the role. And I was very, very different. And that's how came into the national team around about 2000 end of 16 or beginning of 17, and then took it on from there. So yeah, it's that's been the journey really. I think at that point of time, but it wasn't a definitely want to do a national role, because generally speaking, people come into these roles much later on in their lives, I would say.
Well, I think there's a lot of people that say that seeking out one of those roles should be an exclusion criteria. It should exclude you from it. But I'm really interested to know what it was like coming into NHS England, and kind of you're being brought on this national team for the first time.
Mm.
Like, how do you actually? Because you talked about a little bit earlier in the conversation, actually bringing the skills and sort of getting stuff done. That there's a lot of people who can talk the talk, but then they get there and then they don't do anything. So, what did you do, and how did you end up being somebody who's like actually making a difference through kind of your actions?
So I think the first year or 8 months, well, I didn't do anything. I just basically observed and looked around the system, saw what worked. And I think it's more about finding the people who actually held the policies or the influence. I think that's quite important, because I think in these central roles, you end up spending a lot of time with people, a lot of energy, and then after 4 months, you find out they have got absolutely no power to make any change. And you go like, what a waste of time that was, right? And people spend a lot of energy doing that. So I think the first 8 months, 9 months, if not a bit longer, was very much about the scoping and trying to find out who could be the people who would help. I think that was quite key to trying to find the main stakeholders and the main individuals within organizations. And then one of my principles has always been is that I personally think that if you're doing a leadership role, you should have very finite objectives to start up with. Things that you can know they've got a decent chance of actually succeeding, a 50-50 rate. If I turn around and say, I want to improve cancer care, right? That's a lovely ideology, except that it doesn't mean anything. What does that mean? Which bit of cancer are you really improving? So rather than saying, I'm here to improve diabetes care, I specifically said, I want to improve. I want to start by improving people's access to technology in type 1 diabetes, because I think that's a fundamental part of your self-management. And technology is moving at pace around the world, and UK was at that time really behind, right? We were about like 10 years behind the rest of Europe or US. So that was, and I knew there was a finite chance of achieving that, because it was more modern and stuff like that. And I think I went for it absolutely all guns blazing, right? Negotiated with the company, sat down with the DH, said this is what needs to happen. A lot of negotiation to make it happen. And then I had some smaller projects as well. So I think the idea to the system was, over the course of time, is pick 2 or 3 projects, deliver them, create your I would say reputation, and then you move on to the next thing. And the more you build your reputation, the more success comes along with it, and other people with it. And that's been the philosophy, so to speak. But you do find there's a lot of guff and a lot of fluff in NHS England, as with other organisations, where you have a lot of system, I would say, which really doesn't make any sense or doesn't really help take things forward. It's about trying to find your way through it, I would say.
That's actually really helpful to hear as a junior doctor, because those principles that you're talking about, they're kind of universal, right?
Yep.
So even if you're working on your own quality improvement project in a
Yeah.
single hospital, I suppose there's 2 ways you can think about that. You can think, well, this is a tick box exercise, something
Yeah.
that I just have to do, so I'm gonna just
Go through
try
it. Yeah.
and exactly. Or you can kind of use those principles and say, well, can I make a lasting change? Can I do something small, focus on getting that right?
Yep.
Um, and yeah, I feel like that is really helpful. I mean, have you got any other advice to junior doctors that are kind of, wanting to start out trying to make things better, but maybe don't have the reputation, or
Yeah.
don't have the, don't really know what exactly they want to change?
I think what I always say, I've got at the moment I've got about 5 or 6 trainees under me as an ES, as an education supervisor, and I say to them, so I've got a very interesting dynamic with them. My way of doing education supervision is very, very relaxed, right? It's very much like doors open, but guys, come in wherever you want. Tell me what bureaucratic exercise you want me to do. Let's get that out of the way quickly and let's just talk about your life and your career and what we can do to help you. That's pretty much my principle with all my trainees, right? Tell me what box
Mm.
to tick. I'll get that done. Then let's get to the real stuff. So I think the question you asked is quite important for me because I think I always say to juniors exactly what you've said. They go, "Oh, it's a QI program." I said, "What are you doing the QI on?" It's about whether the door was closed properly there in the about the insulin box. And you go like,
I think that's one of the more exciting ideas I've heard.
so I just go like, "Do you want to do diabetes?" And they go like, "No." I said, "Well, why have you picked that?" And they go, "Well, it sounds like a good thing to do, or maybe we should do it." And there's a lot of feeling that maybe I need to get a QI program done. And I always say, no, 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 forget about that. Don't do any of the nonsense like that. Tell me something that you really. And I think people don't do a lot of that because people are always prejudiced by all the other people around them and their seniors saying you need to do this, and you go to a meeting of your, ARCP and all this. Right? You need to. And you've done 3, and if you tick the box and done 25 DOPS and 17 this and that, I get all that. But I think what I always say to juniors, forget all that. You've been on the wards, right? You've been a medical student. You've been on the wards. What's one thing? Forget everything. If you were a patient, what one thing would you like to change? Simple, small thing. Don't worry. We're not talking about you changing the treatment of cancer. No, nothing like that. What's one thing you might have seen if you're, and I always give the analogy of parents. I said, if your loved one or your parent was admitted to the hospital, what have you seen that you'd like to be different? And people always come up with an answer. Always very simple, right? I would like the nurse to be available from the call time or something like that, right? Or water to be available. I said, just do that. Don't have to do anything dramatic. Just do that. Come and talk to me if somebody's stopping you from doing that, because I think that's a really good quality improvement you want to do for an individual. Now, that's based on a personal experience, right? And you will find the person going and finishing that because they actually believe that, okay, that's a good point. I would like water to be
Yeah.
available at the bedside and stuff like that. There's a lot of people that go like, well, what kind of QI project would you have better have been doing, checking all the D dimers that were done in MAU? And you're going like, well, not really, right? There's enough research trials going around for us to answer that question whether we should do D dimers on everybody. But on the other hand, this one about is there water at the bedside every single time you go and do a ward run on somebody's elderly, do you know what? That's a genuine QI work. And I would support that as a consultant because,
Mm.
and I always say to my juniors, if you do a QI work which you really believe in, I'll take it upwards in the governance structure. Find out for me if it's something, if it matters to you, we'll make it matter to other people. So I think that's an important point for me. And that makes QI projects far more interesting. And it's about choosing that one which will appeal to you. And I think when I do the national work, that's what I've
Mm.
always said. If I had type 1 diabetes or my children had type 1 diabetes, what would I like them to do? Would I like them to prick their fingers or not prick their fingers? The answer is obviously not prick their fingers. If I want my children not to be pricking their fingers, I don't want anybody else's children to either. So that's the drive to try and change that. So that's the way I look at it.
Well, I think that anyone listening to this, I think there's going to be a big increase in the amount of FY applications to Portsmouth Hospital because I think that's the kind of educational supervisor that we all want to have. Um, Something I wanted to ask you about is, been in the news recently about the closed loop
Hmm.
insulin pumps that have
Yeah.
been approved. I mean, were you involved in trying to kind of influence this work from the outside?
Yeah, very much so. It's again same thing, So for me, I've always said chronic disease management, especially let's say type 1 diabetes, is and that's always been my driver of the national work I do. For me, hinges on three main things: better self management, better peer support, and access to trained professionals. So all the work I've done has been driven towards that. Peer support is what I do a lot. So I've done like TED Talks with type 1 diabetes. Like I've got another few programs coming up. Today I've tweeted about we're doing a program for people run by type 1 diabetes. That's peer support. Self-management is where the glucose monitoring comes in and the closed loops. So a lot of the work which we have recently just finished with NICE is about making sure that they do the data analysis and review and then puts it into the NHS. So that's something I've been working quite a lot on. So that's probably going to be the next project, hopefully to finish off. It's big progress made with the NICE thing that you referred to, NICE decision. And finally, access to trained professionals. So we're doing a lot of that. So I've been around most of the hospitals in the country, looking at diabetes teams, sitting down with them, going through their data and focusing on their education and access. So that's part of what we call the GIRFT work. So going around looking at variation, etc. So those are the three principles on which I'm working. So closed loops is a big, big part
Mhm.
of that. And yes, that's been a big drive for me as well.
So the kind of the GERF, that's the getting it right first time
Yep.
sort of program that you're involved in, and there's also the kind of the TAD talks that you talked about, and I
Yeah.
think this is something. So my sister is has type 1 diabetes, up in Scotland,
Hmm.
but is still a big fan of your work down in Portsmouth, and I think part of the reason for that is that she feels that as a voice of as a consultant voice, you're speaking up for something that patients actually want and would actually make a difference to patients.
So the patient power is not used enough in the NHS, let's be honest. And I think that I do believe that's the role of the specialist consultant, right? We talk a lot about patient involvement. We don't enough, right? I mean, there's so many meetings I go to, and lots of people talking for people with diabetes or anything, and you sit there going, "Well, none of you got it. How on earth do you know what it's to live with it?" I mean, that just makes no sense, right? There's a lot of paper and effort spent on PowerPoint saying about patient involvement, patient at the center, or whatever, and well, it's not a huge amount. So I think that's where our role sits as specialist consultants. So I do type 1 diabetes, I do type 2 obviously as well. But type 1 diabetes, then you become a voice and you can just stand up and go like, so what's going on with type 1? And they will go. So lots of systems I go to, oh, we're doing a lot of work on diabetes. And you go like,
Mhm.
oh, really? What are you doing? And they go like, oh, yeah, no, we're doing loads of progress on prevention. I said, that's interesting. Well done. How are you preventing type 1? And they will go like, well, oh, yes, we can't prevent that. I was like, exactly. So now that you've spent all your money on prevention of type 2 diabetes, what exactly are you doing for type 1? And they will turn around and go like, okay. So I think that's an important thing because you need to have the
Mhm.
continued focus in all areas to sort of progress. Yeah.
That's a really interesting idea because it's almost like you're talking about collaboration between medics and patients as collective trying to improve care,
Yeah.
and that's something new that I've not seen that in a lot of context. What I've seen more of is maybe there being a little bit of fear amongst medical professionals of patient groups, especially in the context of complaints. Like, oh, all of these patients are going to talk about some stuff which we can't offer, and then they're going to put in a complaint because we can't deliver that. And how do we manage all of those relationships without it affecting our jobs? Um, it's I would much rather do it your way.
Well, I think there's I always find that I think there's a lot of misunderstanding. There's a belief that patients will get really angry if you can't deliver X, Y, and Z. People who live with diabetes or any other condition, right? They're the same people who we go out and meet out in the streets every day. People are realistic. They're not blind. They can read what's happening in the papers and what pressures the NHS are under. I don't think what people don't appreciate is that if you turn around and say, we will give you all cake or something like that, and then you go like, well, actually, there's no cake. There's only some rusk bread, right? And you go like, well, hang on a second. Why the hell did you say you're going to give us cake? And I think that's the problem, right? On the other hand, when we went to do the policy role, we were very clear. Look, I'd love to give everybody, all of you, the Freestyle Libre, right? The non-invasive glucose, everybody. But I can't. My hands are tied. That's the money we have. So I tell you what, we're going to start slow. We're going to start at 10%, then we're going to get a 20, and we'll make sure everybody gets a 20. And now, guess what? The country's at 40% of the type 1s have got this device. So you see people, and then you're setting the expectations, and people appreciate that you're at least being truthful with it. And I don't think that's where this whole dichotomy sits. You go, like, what will people think? Well, people will think obviously not very well of you if you keep on making unrealistic promises. So if you say that, your sister's got type 1, if a doctor or a nurse says, don't worry about it, you can contact us anytime. And then your sister, heaven forbid, does contact them one evening at 10 o'clock at night because she has a problem and gets a no answer. Well, what is your sister supposed to feel? Well, not very happy because you made that promise. Don't make unrealistic promises, right? What
Mhm,
I would say to my patient, absolutely, email me whenever you want. But hey, listen, I've got a life, okay? I'm just like you. I finish work.
mhm.
Between these times, I will try my best to answer all of the time. But beyond that, it may not always happen. So in case you've got an emergency, don't call me. You need to do X, Y, and Z. and people are really appreciative of that because you've been truthful at the very beginning.
Mm.
You just said like, okay, I'm a human being. I need to go and enjoy my life and have my drinks and go, spend my time with my family. And I think that's what I would say. That's my experience. I've had nothing but love and support from the type 1 diabetes community. They have been, I mean, without them, I don't think I'd be able to achieve anything. They've been amazing.
Mm. And it's kind of echoes that kind of idea of fire and ice that you were talking about. It's not just about negotiations; it's about like honest communication with patients as well, isn't it?
Absolutely, absolutely.
And I'm kind of wondering, you talked about having a life, and work life balance is really important. Hot topic about well being amongst junior doctors at the moment.
Yeah.
So as someone who kind of maybe to the rest of us appears to be kind of driving forward a lot of the ideas and kind of have a sort of a national presence, how are you juggling, all of this? So how do you juggle the ward, the outpatients, maybe the national work, the kind of other projects that you're working on? How do you structure that?
So, I mean, some things are privilege in the sense of being very lucky. Luck and privilege is a big thing. Not everybody's got it. So, and I hate when people go like, well, actually, you should spend time with your family. And you go like, well, lots of people don't have family, right? Or they may not have a very happy family with them. So it's very easy. So I think luck and privilege has got a big role to play. I'm a consultant. I get paid well by any standards, and I've got a very supportive family around me, etc. But the other things which I always say is that people really need to learn to switch off. And a lot of doctors don't do that. And I do mean junior doctors. You see social media, right? People get angry most of the time and get involved in X, Y, and Z, and then just go on into, really get sucked into some sort of absolute fireball. Lots of them are trainee doctors, right? And I can
Mm,
understand that because they're angry about a particular topic, whether it's sexism, whether it's racism, whether it's something stupid to say. But you really wrap yourselves into it because at the moment there's no other life beyond it. And my advice is to learn how to switch off from social media. We will mostly, all of us will have a select few friends who will never judge us for who we are, right? We all have some of those in our lives who will just sit down and, I've got friends who, when I sit down with them, it doesn't matter to them who the heck I am, which is great. Bring you down to earth in 2 seconds flat, have a drink, joke, saw you on TV looking like an absolute idiot with your hairstyle, man. Why would you do that? That sort of stuff. But that's my advice to
yeah,
people.
you need that. You
Yeah,
need that.
absolutely. So you need those group of friends. You need good food, holidays, difficult at the moment, enjoyment, and time out from all these things. The world's tough enough anyway, right? And social
Mhm.
media makes it explode even more. So and you get into a bubble, isn't it, where you think everything is bad. I mean, some days you wake up, open
Yeah.
Twitter, it looks like, well, the whole world has collapsed. So you just need to sometimes just take a break from that.
I'm kind of wondering if it's easier to switch off as a consultant. It's interesting that you're saying that a lot of these people that maybe are finding it harder to switch
Mm.
off are people who are more junior like me.
Mm.
Maybe they feel that they've got to prove themselves, or that I'm really working hard for this sort of post, so I can't, or that it's scary to speak up because I'm not in a position of power. The hospital could easily get rid of me if
Yeah,
I'm claiming that the hospital management's
yeah.
institutionally racist,
Mm.
or all the rest of it. Is it easier to speak up as a consultant?
100%. 100%. No question about it. Anybody who tells you otherwise is telling you a lie. I mean, the system's completely hierarchical based, right? And even now, I'm a national NHS England. I get emails going like, "Whoa, are you sure you wanted to say that on Twitter?" And I go like, "Yeah, I did actually." So yeah, I'm quite comfortable where I am in my stage of my career because when people
Mm,
go like, "Oh, you're so vocal about racism," what happens if they say to you, you shouldn't do the national role anymore?" I said, "That's fine. I've done my job. I achieved X, Y, and Z. I'll go back and be a consultant where I am, and if they don't want me there, I'll go back to India. I'm good. I'm good.
mm,
I'm at that stage of my career. For somebody who's in their 20s or their early 30s or whatever, it's not easy. You still have to establish yourself. And I think this is where I go back to the very beginning of what I said, where you need the support of some consultants to go like, nah, it's okay. It's all right. I'll stand by you. If somebody
mm.
from management goes like, I didn't like his tweet. So I've got that, right? About as educational supervisor, I'll have somebody coming around and saying, have you seen your trainee's tweet? I always go like, have you seen mine? Right? And we always laugh about it. And I said, look, if they're not publicly insulted the institution, they're not being racist, sexist, or any of that. It's a view of an individual, right? You may not like it, but if it's not a swear word or said something or brought you into disrepute, and even that is not easy to prove that you brought anybody into disrepute. If you're saying the truth, you're saying the truth, right? I say stuff about
Mm.
NHS England. I work for NHS England. I would clearly say X, Y, and Z is not right, and people, I haven't had any censorship on that. But I think that's also because of the support. So that's what I would say, is that there is a careful line, but I think that's where
Mhm.
you need your supervisors as well to stand by you and sort of go like, but also be careful about what you're doing. But yes, 100%, it's much easier to speak out when you're a consultant than when you're a trainee. No question about it.
Yeah. Now, uh, my sister wanted me to ask a particular question. So she's someone who, is eligible for a Libre sensor, and but can't have it because not because of availability, but because she's allergic to the adhesive.
Yeah,
She developed an
yeah.
allergy, and she's kind of thinking, what are the next stages of the technology going to be for people who, these particular things aren't working for?
So specifically for your sister, if she's been allergic to the D7, the first one, right, the Libra one, the Libra 2 has got slightly different components in it, so she might not
Mm.
be allergic to it. So that might be worth trying. And there's very clear documentation that if the Libra doesn't work, she could try the Dexcom. For people who are allergic to one, she can go to the other one, which again has got different adhesives, right? If she's allergic to all of them, then I think the next stage of things that are coming through is probably to keep an eye on where Apple is going with their watches. And I think that's
Mm.
probably is going to be the complete game changer, because if you look at Apple's progression, they did the heart rate, then they did the ECG. Glucose monitoring seems to be a very, very obvious next thing to do, because there's such a big impact on not just people with diabetes, but also there's so much fanaticism around the whole glucose levels and stuff. I suspect that will be
Yeah.
a big thing going forward. So that probably is coming on your Apple Watch in the not too distant future, I would say, if I had to make a punt.
Oh, she'll be really excited about that. So, and sort of coming to the end of the conversation now, but I just, wondered about, you know, going into diabetes
Mm.
as a specialty, or, endocrinology, because it's much larger than just diabetes. Um, like, it sounds like you're really happy that you've made that choice, but did you always know that you wanted to go into diabetes, or, how did you settle on that?
Not at all. I mean, I think it was very much driven. I mean, we were lucky in those days, right? When I was in SHO, we had an opportunity to do all specialties we wanted to. We had choice, right? It wasn't
Mm.
just allocated. So I remember doing respiratory, cardiology, gastroenterology, renal, elderly medicine, a lot of specialties, going around, generally getting an opportunity to go around. And then when I went and did diabetes, I had a fantastic mentor. It was amazing. It still is. I mean, David Jenkins, he was brilliant. My first clinical attachment was with a endocrinologist, Tony Zalin. But David Jenkins probably had a big bearing on my life about picking this as a
Mm.
specialty. And he always made me feel that you could change people's lives, but be a part of their journey. It's a chronic disease. It's not like one of those things where you just do one thing and move on. And that's been quite good. That's been quite good for me. So that's why I chose this specialty.
Yeah. And so, where do you see yourself? Sort of, what are the priorities for you next? What kind of things do you want to work on?
So, I mean, I think type 1 diabetes wise, I think, we've done so many good things, I reckon, with a lot of the community. I think that journey probably is going to come to not a distant end at some, because I want to get technology and self management embedded, and we've done lots of that in the systems. The NHS, I think, is in a position where you won't go back on that anymore on type 1. That door is open. So I don't know. I mean, the whole racial thing intrigues me, for me to sort of get interested in it. I
Mm.
haven't decided what I want to do straight away. I think diabetes wise, my next thing I wanted to do was make sure hospitals were more safer. I think safety in hospitals. I wanted to make sure that if you came into hospital, that you felt safe, and that's not an issue. That is a big issue at the moment. But then, the racial thing does intrigue me. I don't know whether I want to get involved in it, whether I just want to take a break for a little bit. It's been sort of full on 4 years, so to speak.
Yeah.
So, yeah.
I mean, the report that came out this week, did what was your impression of that? Because
So
it
that
seems to have got a massive backlash for a report that seemed to be trying to claim that, um, racism had largely kind of been solved, and the next question was kind of how do we resolve disparities in other ways without looking to race as the explanation.
Well, I mean, to put it mildly, it's a joke, really. I mean, I'll give you one example. Apart from the emotive side, right? There is I read the report actually. So I read the report, page 208 to 209. I wrote it down the other day. There's a section on diabetes, right? Okay, let's put it to you this way. They've done a section on diabetes. They actually haven't spoken to the diabetes leads of the country. We have the biggest data set in the whole of the world as far as diabetes goes. Nobody's asked me to give them any data or do any data analysis based on ethnicity. I mean, if they did, I could have told you, for example, if you've got type 1 diabetes, you have got much less chance of getting access to a technology if you're a black child rather than a white child. That's got nothing to do with deprivation. That's straightforward, a color thing, right? But there we are. So nobody's asked me. So that's the level of joke I think that document is. I'm not sure who they've asked, but there you go. So I think it is what it is. I think system has reacted quite loudly against it, which is good. And I think going forward, in one way, it's a good thing, right? It's actually drawn more attention towards it, so which is great. So,
do you think that you'll send maybe a anonymized part of your data set into them and say, "What about this?"
I don't know, nothing anonymized. I probably would just put my name to it and go like, "Hello, guys. It would be lovely if you'd asked me. I could have told you what else is going on." So, I think I tweeted this morning saying, "Nobody's asked me from NHS England. I'm supposed to be one of the diabetes leads. Nobody's asked me. So, what can I say?"
Do you think that's something we're starting to see with the race issue, that now there's a kind of reaction saying, well, actually, racism's not as much of a problem as it was, so we don't need to focus on it as much anymore?
No, I think in health, there is a lot of noise around it. I think, after COVID, where there's very clear evidence as what sort of, different levels of outcomes and everything, it would be really silly and difficult to say that, nah, it's all right, don't have to worry about it. So I think that, it'll be interesting to see things going forward. And certainly in the health sector, there isn't a lack of appetite to make those changes happen. And lots of people are in very strong
Mm.
positions right now at the top to sort of ignore that sort of level of, views and take things forward.
So, very last question. I always ask if there's a book that you've read that's been influential on you, or that you think people should go out and read if they want to sort of go a bit deeper into some of the things we've been talking about.
So I can give you lots of examples. I like reading books, but I always, when I'm asked this question, I never give a particular book. Because I'll tell you why. Because I have always been, it's well known, my love for comic books, right? And what I always loved, and there is a particular comic book that I always like, which was a comic book called Civil Wars, done by Mark Millar. And it talked about how superheroes spent a lot of time fighting with each other over some very simple stuff about the government trying to impose this and that and going back into camps, etc. And I always reference that simply because that's where we are in the NHS at the moment. Camps and divisions.
And people fighting each other instead of working together.
Yeah, and that's such a good book. It also shows the importance of what I call teamwork. Whereby everybody thinks whether you're a doctor in orthopedics or a doctor in X and Y, people feel they're fantastically strong on their own. And I can tell you for a fact when you talk about consultants, you said consultants feel like I don't have the power. Well, you don't have the power because you're sitting there on your own. You join up with your colleagues across surgery and X, Y, and Z. I cannot even begin to tell you the power you wield across the system. We just don't do it enough because the system does it very well about dividing us up and fighting amongst ourselves and having battles over nothingness. And that's always a good comic book which I reference people to read and how it ends and where it goes to. So that's what I always use as a reference.
Well, Partha, thanks very much for chatting to me.
Thank you.